So this lesson is about typhoid fever, and I am going to go through the following: causative agent of the disease, pathophysiology, clinical features, diagnosis, treatment, and prevention. So stay tuned to the end.
This type of enteritis is caused by the microbe Salmonella typhi, ingested in food and water. Humans are its only host, so the source of contamination is an individual who is either suffering from the disease or is a carrier. After ingestion of microbes, there is an incubation period of about 14 days before signs of the disease appear.
During this period, the microbes invade lymphoid tissue in the walls of the small and large intestine, especially the aggregated lymph follicles, Peyer's patches, and solitary lymph nodes. The microbes then enter the blood vessels and spread to the liver, spleen, and gallbladder. In the bacteremia period, acute inflammation develops with necrosis of intestinal lymphoid tissue and ulceration of overlying mucosa. Other effects of Salmonella typhi or their endotoxins include typhoid cholecystitis, in which the microbes multiply in the gallbladder and are excreted in bile, reinfecting the intestine, red spots on the skin, especially of the chest and abdomen, enlargement of the spleen, myocardial damage and endocarditis, liver and kidney damage.
Reduced resistance to other infections, especially of the respiratory tract, e.g. laryngitis, bronchitis, pneumonia. Uncomplicated recovery takes place in about 5 weeks with healing of intestinal ulcers and very little fibrosis. Ulcers may penetrate a blood vessel, causing hemorrhage, or erode the intestine wall, leading to acute peritonitis. The individual may become a carrier. When this happens, the typhoid fever becomes a asymptomatic infection of the biliary and urinary tracts. Microbes continue to be excreted indefinitely in urine and feces. Contamination of food and water by carriers is the usual source of infection. Typhoid fever is endemic in many regions of East Africa, although epidemic outbreaks have occurred when a source of water or food used by many people has been contaminated. The disease has a case fatality rate of 3% with treatment and 10% without adequate antibiotic treatment. Human beings are the only known reservoir and host. Clinical features: the incubation period of typhoid fever is 7 to 21 days. The disease has a gradual onset which progresses through the following 4 stages. First week, stepwise fever. During the first week and early in the disease, the patient has severe headache, malaise, loss of appetite, body pains and aches, and a tendency to nosebleed. The body temperature rises day by day or in steps to 39.5 degrees Celsius or higher. Most patients cough because they develop bronchitis and may also complain of constipation. Second week. Rose spots. In the second week, temperature continues to rise, but the pulse rate is slower than would be expected for that temperature. There is swelling of lymphoid tissue in the intestines as well as Peyer's patches, necrosis and ulcers, which cause the abdomen to become distended and tender. The high temperature and toxemia causes mental confusion and disorientation in the patient. Half the patients may develop greenish watery, pea soup, diarrhea and bronchopneumonia. Third week, body temperature decreases step by step and the patient improves slowly. If there is no improvement, the Peyer's patches in the intestines perforate and toxemia increases. The patient becomes delirious and incontinent of urine and stool, muscles twitch and coma may precede death. Hepatosplenomegaly, typhoid encephalopathy. Fourth week. For the patients who do not suffer the serious complications of the third week, the fourth week is a period of convalescence. The temperature drops back to normal and the patient recovers gradually.
Diagnosis: the best way to diagnose typhoid fever is through a blood culture. This may be positive during the first week and for a variable period after this. Stool and urine cultures can also be made, although they are only positive after the first week. Other tests which are undertaken include Widal test during the first and second week, that is indicative of high and rising titers, WBC count, which indicates low levels, leukopenia, with raised lymphocyte count. Stool to check for presence of occult blood, which is found in 100% of the cases.
How reliable is the Widal test in typhoid diagnosis? Although the Widal test is still very useful, especially when two tests are performed 4 to 5 days apart after the end of the first week, its interpretation is full of difficulties, especially in endemic areas and in people who have had the typhoid vaccine. That is why it is a good idea to also carry out one of the other laboratory tests. Treatment: fluid replacement due to diarrhea. Oral norfloxacin 400 mg 12 hourly for 10 to 14 days. Oral ciprofloxacin 500 mg BD for 14 days. Severe cases, you can introduce a steroid. Dexamethasone contaminated articles should be disposed by incineration. Stools and urine should be disposed of in a pit latrine or septic tank. Surgical treatment for perforated bowels.
Prevention and control. The prevention and control of typhoid fever is similar to that of many diarrhea diseases. It includes identification of the carriers, especially those who work as food handlers, and treat them promptly, administration of typhoid vaccine, safe water supply, improvement in food hygiene.